We're taking this, 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 we're taking with a pinch of salt.
Dear colleagues, welcome today in a pinch of salt, a very special pinch of salt, which is proposed as always by the ERA. I'm George Kosmadakis, your host today, and the subject we'll try to clarify a little is the hepatorenal syndrome. The incidence of hepatorenal syndrome in patients with decompensated liver disease is approximately 4%. The most common precipitating factors of hepatorenal syndrome are spontaneous bacterial peritonitis, large volume paracentesis of ascites without plasma expansion, and gastrointestinal bleeding. There are two types of hepatorenal syndrome. There are various therapeutic options with conflicting outcomes like terlipressin and albumin, or noradrenaline and midodrine or octreotide. All this will be clarified today by our guest, who is Professor Juan Carlos Velez from Ochsner Medical Center in New Orleans, USA. Juan Carlos, welcome to the Pinch of Salt.
Well, thank you. Thank you very much. My pleasure to be here. I love the name of the podcast.
Well, it was the idea of the other guest, the boss, Dr. Skoberne from Slovenia. And we'll start straight away with the first question, Juan Carlos. What is the prevalence and epidemiology of hepatorenal syndrome?
Thank you. A important question. And interestingly, the number you cited earlier, it's a correct one for the whole scope of patients with decompensated cirrhosis. But I always like to give a different perspective. So the risk of a patient with decompensated cirrhosis to develop hepatorenal syndrome in the course of 5 years can be up to 40%. So yes, as a cross-sectional number, it may seem low, but when you look at the individuals themselves, the risk becomes higher over time. The other way to look at it is as a nephrology consultant, I look at the population of patients in a hospital with AKI and cirrhosis that we get consulted. So first, we recently published through the Harmony Consortium in a population across different centers in the United States, 2,000 patients, all etiologies of AKI and cirrhosis. HRS, hepatorenal syndrome, accounted for 11% of those cases. But then we will look here at our center of just those in which a consultant nephrology was placed, it increased to 35%. So it's kind of a relative. You work in a transplant center, you're going to get more referrals of patients with HRS. So it is not extremely common, but I don't think it's necessarily a rare disorder in decompensated cirrhosis.
Well, of course, it is not very common, but it is a subject that sometimes would not feel very comfortable when we are asked for help by the other specialists. That's why we decided to do this podcast. It is rare, but also it is something that we are not very familiar with, and that's why this 5-year 40% risk is huge for this group of patients. Could you explain the various types of hepatorenal syndrome?
Yes, hepatorenal syndrome historically was classified as type 1 and type 2. Type 1 being the acute form in which the renal function declines fairly quickly, typically in the course of 2 weeks. Now the new definition uses the standard KDIGO definitions of acute kidney injury, and is now renamed as HRS-AKI, but it's the same entity. I still call it HRS-1. And then the HRS-2 was assigned to those individuals who will have a more insidious progressive decline in kidney function, typically those with refractory ascites. They would have a decline in kidney function over the course of greater than 2 weeks, typically 2 to 3 months or more. So those have been now reclassified as HRS-CKD for those who fit the criteria of HRS chronic kidney disease, and HRS-AKD, which is acute kidney disease for those who have greater than 2 weeks, but less than 90 days of renal dysfunction. But again, it's just terminology that helps for clinical trial enrollment. The overwhelming majority of patients that we encounter in a hospital setting are HRS1 slash HRS AKI. Occasionally, I see in the outpatient setting some patients that behave like HRS2 or HRS-CKD, but those are not the challenging ones that we have to encounter in the hospital. And I agree with you about the sort of the challenges that we face when we try to decipher those cases, which is the reason why I got into this field, because it forced me to kind of read more and try to learn, understand more this complex entity.
Of course, and I have to tell our friends that you are a big specialist on the matter, so that's why we try to ask for your help on this. Could you please explain to us, with a few words, the mechanisms of hepatorenal syndrome? I know there are some conflicting theories about this. Could you elucidate some modern perspective on this?
Yes, yeah. So I will start by saying that the backbone of the pathogenesis continues to be the traditional hemodynamic derangement in which a stiff liver, fibrotic liver that has increased intrahepatic vascular resistance leads to an extrahepatic maladaptive response in which there's a splanchnic vasodilation and a fall in the effective arterial blood volume, and that leads to a compensatory increase of the renin-angiotensin system in the sympathetic nervous system that essentially cause local renal vasoconstriction and a marked reduction in renal blood flow, therefore in GFR. That continues to be the most well-established and described element of the pathogenesis. Over the last decade and a half or so, numerous studies have now try to challenge this by adding other elements of the pathogenesis. Inflammation, one of them, another one related to sort of a cardiac component of the hemodynamic derangement. Some studies looking at cholemic or bile cast tubulopathy, aggravating the pathogenesis, abdominal compartment syndrome, and in general, I would say that all those elements of the pathogenesis are probably contributing, and this is why it has become more difficult to dissect. And we have to accept that in numerous scenarios, patients will present with more than one element of the pathogenesis. They will have traditional sort of a hepatorenal physiology with that results from renal vasoconstriction, but they may have a tense ascites causing abdominal compartment syndrome. They may have a bilirubin of 42, and that will cause some bile salt tubulopathy. So I think it's now no longer a single mechanism. I think we now understand it as a multimodal pathogenesis.
A multimodal pathogenesis with splanchnic vasodilatation as a cornerstone of this mechanism, a reduction of the relative circulating volume, finally a functional AKI due to the
Yes, it is functional AKI, and
vascular hyperperfusion. Yeah.
correct. There could be some degree of acute tubular insult, but it's usually not the primary driver of the fall in kidney function.
Right. No direct renal toxicity. What about hypoalbuminemia? Is this contributing?
Hypovolemia is present in most cases. It has become a difficult factor to assess. We being a referral center here at Oxford Medical Center for Transplantation, the majority of patients arrive already receiving doses of albumin at outside hospitals. So we don't encounter patients very hypovolemic on arrival anymore because of how much albumin is being given prior to transfer. So hypovolemia is a typical element of the phenotype. Most patients that have been treatment naive will come with an albumin of 2.9, 3.0. And whether that contributes to the pathogenesis hasn't been clearly established because we don't, for instance, it's not HRS patients don't have more profound hypovolemia than those who don't develop HRS. Um, Other elements of the phenotype appear to be more associated with the risk. For instance, low blood pressure. Patients that have lower blood pressure baseline tend to have more risk for hepatorenal syndrome, and intense ascites, and other elements that are associated with the risk, hyponatremic patients, etc.
So these are markers, probably some coexisting factors that are present at the same time, but we're not sure that they play a significant role in the pathogenesis of this condition. Well,
Exactly.
now, Juan Carlos, I will ask you a question which is also my personal question. Which are the treatment strategies? How do you treat hepatorenal syndrome today in 2025?
Yeah, great. Thank you for the question because this is one of my favorite questions. Well, I think it starts with a very careful assessment. Very careful assessment. The primary task that we have is to determine if the patient has hepatorenal syndrome either as a single cause of AKI or as the major contributor for the AKI, because we have to accept that it may be more than one process happening in a patient. Let's say a patient received doses of vancomycin, it causes acute tubular insult. So, but at the same time, the patient has HRS physiology. So it's our job to determine, okay, which of the phenotypes is dominating, because if the HRS phenotype dominates, we have an opportunity to treat for HRS. So we go through the process of reviewing the chart, looking at examining the patient, obtaining labs. There are certain characteristics that phenotype I mentioned earlier. Patients are typically they have a predominant, they have a precipitating event. They have, for you mentioned earlier, spontaneous bacterial peritonitis. Patient has SBP, my suspicion is already a little bit higher because that is a common precipitant. Or patients have progressively more refractory ascites. That's another typical phenotype. Then you look at the blood pressure. If blood pressure is 150 over 90 at arrival, I'm gonna have very hard time even considering that a patient has HRS. That's just not, even though it's not listed as a criterion, it's the phenotype, right? Most patients are gonna be, blood pressure will be normal, but in the low side of normal. They'll be like a 105 over 58. They'll be hyponatremic. They're gonna have obviously ascites, and various degrees of jaundice. And then you look at the urine abnormalities. You're gonna look at the urinary sodium is typically less than 10. If the urinary serum is 58, that doesn't look like an HRS physiology. And then we do urinary sediment microscopy. That's a standard of care for our center. We want to make sure there are no obvious evidence of something that involves a renal parenchymal disorder. This patient with cirrhosis may have, you have Hep C, they have a membrane proliferative GNs, IgA nephropathy. Sometimes we catch elements of GN, so we cannot miss that. And then we look for evidence of acute tubular insult. So as I said earlier, sometimes you may see a few granular casts, but if the slide shows a really abundant presence of muddy brown granular casts, that is going to point us in the direction of acute tubular insult. In classic HRS, the urine sediment is typically fairly bland or just loaded with hyaline cast, which denotes sluggish tubules and still nephrons that could be rescued by a therapeutic intervention. So once we go through that process, we determine, okay, this patient fits all the elements of HRS. Let's treat this patient. And the next question is, in our institution, if the patient is on the regular floor, we have an opportunity to treat with terlipressin. If the patient is in the ICU, we typically use a norepinephrine because it's at least less expensive in our center, and the patient is already in the ICU. We don't have to transfer the patient. But on the floor, terlipressin has become the number one therapeutic intervention. Midodrine and octreotide is given as candy by the hospital medicine team. Almost everybody in the hospital with cirrhosis and AKI receives midodrine. It's largely ineffective. We use that when cases are really mild and we're not certain that whether the patient has or not has an HRS. We may give 24 hours of that trial. But if we have already determined that the HRS diagnosis is likely, we move to use terlipressin. And before we do that, we go through a careful assessment of the volume status. So we do not want to use terlipressin when the patient have pulmonary edema, hypoxia, echocardiogram denoting diastolic or systolic dysfunction. We are very careful not to expose the patient for a risk of respiratory failure that was unveiled through the confirmed trial. So once we go through all those checklists and the patient has absolutely no evidence of fluid overload or respiratory compromise, we use terlipressin. And note that I didn't mention this albumin challenge, and because I think it's important to know that you have to be very patient, sort of selective, in the sense that not everybody should be put on a basket of giving albumin for 40 hours. That was kind of the old approach. The newer guidelines that came out in the Journal of Hepatology last year from the ADKI and ACI was part of that consortium. Now you can try 24 hours of albumin if it's reasonable and the patient appears to be bone depleted. But if not, if the patient arrives overloaded, you can go ahead and move on to the next step, which is determine if the patient qualifies for norepinephrine, or I'm sorry, for a vasoconstrictor, which could be terlipressin or norepinephrine. And then if once you initiate treatment, we pay attention to the milliliter pressure. We want to increase the milliliter pressure about 50 milliliters of mercury from baseline, which is associated with a greater probability of therapeutic response. So that's kind of the general approach. Of course, there are other elements, but I'll stop there in case you want me to expand in another aspect.
Well, no, no, it's wonderful. I really uh, like the fact that you dedicated one third of your answer concerning treatment on the differential diagnosis, and this is of huge importance because we might have multipathological patients and multiple possible causes of this injury, and be fixed with the hepatorenal syndrome, and have wrong perceptions concerning the cause of this situation. So thank you very much. It's a very important issue. Well, I understood that midodrine and octreotide are not very convincing, and the cornerstone of treatment is either terlipressin or norepinephrine, depending on the situation, taking into account always the fluid status of the patients. Thank you very much. Very, very interesting, Juan Carlos. I think now I will pass to the most difficult question, the last one. If you were in a desert island, which book, luxury item, and two songs would you take with you?
Wow, that's a very hard question. But let's say, just top of my head, I would say the book, probably Barton Rose book, the Barton Rose Book of Physiology. It's one of the reasons why I got into nephrology. I'm lucky to be part of this podcast called Channel Your Enthusiasm, where we go through the Barton Rose book chapter by chapter. And even though I've read the book a few times each chapter, I'm still learning because certain things that I didn't pay attention or didn't understand. So yeah, I would take that book. The next part of the of my package for the island trip was something luxurious. Um, I would say I would take a picture of my family. If I'm gonna be alone in an island, um, I would like to look at a picture and remember my family, which is the best thing that happened to me in my life. And uh, two
Two songs.
songs, two songs. Well, I was in high school in the 80s, which is when the time Metallica became a very popular metal band. So I'm at this in my 50s. I'm still a metalhead. So I would take a couple of songs from Metallica, Master of Puppets and Ride the Lightning, because I love I love that music. It kind of pumps me up and keeps me going. And then what else? That's it. That's any other item I can take to this trip, or that was it.
Well, it's perfect. We'll do the list of the books at the end of the year, and the playlist of all the songs.
Oh,
So at the end of the, we don't give names. We just put the
oh,
playlist of everybody,
okay.
everybody. So it's there's a kaleidoscope of various music genres, and we didn't have Metallica until now, which is
Yeah, we're
wonderful.
gonna have Metallica next to Frank Sinatra, probably, huh?
Yes, well. Leonard Cohen is very often as
Yeah,
well, and
yeah.
Bartolozzi, I met him personally
Oh,
in Boston when he was doing this seminar, nephrology seminar, a very dense week every year by the
yes, yeah,
Harvard University, and well, it is an amazing experience. So, dear
yeah, great.
colleagues, the landscape of in hepatorenal syndrome treatment options might be evolving and that might improve the dismal outcomes of these patients. We hope you enjoyed this podcast. Do not hesitate to listen to other Pinch of Salt podcasts available in all digital platforms. Take care.